last week.
Good morning, everyone, and welcome to Lynn Cancer Institute's Keeping You in the Know in our 2024 series. So this is our first in January of 2024. We're grateful to have you all with us today and to learn from our very own physicians who will educate us on the newest information on gynecological cancers, with a special focus on the HPV vaccine and its impact on cancer. In our physician panel presentations, we'd like to educate you on early detection and screening, diagnosis, and treatment options, as well as prevention. At the Lynn Cancer Institute, we believe that this education, along with the expertise of our staff and our latest technologies, will truly save lives. In the interest of time, the bios of our physician panel were sent to you by email. Your Zoom will be muted during this presentation. So we invite you to please take notes, and when you have a question, please write them in the Q&A or the chat box. The speakers will not be able to see you or hear you during their presentation. So your written questions will be addressed at the end of the presentation. Now, we're very proud to welcome you to the Lynn Cancer Institute and present the three physicians that will be speaking today. Dr. Thomas Morrissey, the Director of Gynecological Oncology at LCI. Our second speaker will be Dr. Lloyd Berkowitz, Medical Oncology at the Lynn Cancer Institute, and Dr. Anurag Agarwal, Radiation Oncology at the Lynn Cancer Institute. We'll begin with Dr. Morrissey. Dr. Morrissey.
Hi, so I share my screen here. Is that what we do? All right. Well, welcome everyone. Again, this is my third year doing this. I joined Baptist about 3 years ago, and so doing this talk. And before I was doing it all by myself. Now I have a chance to share the spotlight with Dr. Berkowitz and Dr. Agarwal, so we can kind of split things up. This year, I was specifically asked to touch more on cervical cancer and HPV. Again, we usually get lots of questions about that, so I'll spend most of my time talking about that. I think I can go forward here. So talk about cervical cancer, the scope of the problem, and a lot more about HPV infection. As far as the treatment, I'll leave that to my colleagues a little bit more. And again, we also want to touch a little bit on ovary cancer and endometrial cancer as well today. So a packed agenda today. January Cervical Cancer Awareness Month. In terms of it's a huge worldwide problem. Obviously, over 500,000 women worldwide get diagnosed with this. In the United States, it's becoming less and less of a problem because we have very good screening, very good prevention. I'll go over kind of the data for that briefly, but still in the United States, even with our very good screening programs and treatment programs and prevention with HPV vaccine, we still have 13,000 deaths or 13,000 cases of cervical cancer in the United States and 4,000 deaths, which again, most are preventable. And so we are trying to get better and better, and we're doing better and better with that. HPV is a virus that it's very prevalent in the world. About 80 to 85% of all people get exposed to HPV, and most people see it like any other viral infection. Their body's immune system kind of sees it, controls it, and prevents any problems from it. But some people who are otherwise completely healthy get exposed to these viruses, and over many years could develop precancer and eventually cancerous changes. And so it's very important to have screening, because we don't know who will have problems with it and who won't, because everyone's otherwise healthy. The other thing is the importance of vaccination to significantly reduce the risk of chances. The other thing is with the screening guidelines we'll talk about. These are changing a little bit, but it's still important to go for regular checkups and regular screenings. In terms of getting pap smears every year, it may not be necessary to do that in people who've had normal pap smears in the past. We may be spacing those out to every 3 to 5 years, and also doing HPV tests instead of pap smears. Again, still the swab the exam for that's the same, but in terms of how often things need to be followed up would be discussed with your obstetrician gynecologist. Cervical cancer, like I said, about 13,000 cases a year in the United States with 4,000 deaths. Most of these are caught at early stage because we have very good screening, and most of early stage cancers are curable. Again, can be cured with either surgery, treatment, or sometimes radiation and chemotherapy. Again, medical oncology and radiation oncology will talk a little bit about that as well. Almost all the patients in the United States who have cervical cancers that have spread and cervical cancers that aren't curable, most of them have not had a pap smear or a pelvic exam in more than 5 years. So this is something that develops very slowly. There's a lot of chances to prevent this and catch this early. And so again, it's one of those things that we have to encourage and people to be educated and keep up to date on their routine screening for cervical cancer. HPV, again, like we talked about, is the most commonly transmitted STD worldwide. About 80–85% of the United States population has been exposed to HPV at some point. Most people, their infections go away without the people even knowing about it and clear of that treatment. However, a small percentage can persist in the cervix and cause precancerous changes and eventually lead to cancer. But again, we usually takes at least 5 years to develop. So if people are getting regular screening, we can pick these changes up early and treat them before they become cancerous, or if they become cancerous, catch them at a very early stage where things are very curable. Other cancers are caused by HPV. We're learning more and more about this. Again, it's cervical cancer is obviously the one where we kind of found out that HPV can cause these types of problems, but cancer in that genital area, the vaginal area, the vulvar area can be caused by HPV. And also can cause cancers in other areas. I didn't have that slide, but can cause head and neck cancers. We're realizing that some proportion of those are caused by HPV infection. So again, this is a virus that can cause multiple different problems in multiple different areas. HPV infection is thought to be necessary. Again, most people who get an HPV infection don't get cancer, but people who don't have HPV infection don't get these types of cancers. And so that's again how we kind of figured things out originally, that you need the HPV infection, so it's necessary to have that. But most people who get it don't get cancer. I want to make that clear. HPV vaccine that we have, again, that we're vaccinated. I'll go over the recommendations, but it's a highly effective vaccine that we give to, it's recommended to give to the teenagers. The target age is at age 11 before most people become sexually active to any extent. And it's 98 to 99% effective in reducing precancerous changes and cancers. The vaccine's been around over 15 years, found to be very safe and very effective. A booster is not needed. And in long-term studies in Europe and the United States, that it's shown that it's been effective over a long period of time without a need for a booster. So again, it's been shown to be 98 to 99% effective. The recommendations for HPV vaccine in the United States is for children and adults aged 9 through 26 should get it. For the American Academy of Pediatrics, they try to aim for an age of 11 or 12. At that point, the kids just need 2 shots. They're usually given about 6 months apart. If you get the vaccine over age 15, they actually need 3 shots for it to be maximally effective. So that's one reason to encourage people to get it a little bit earlier. The vaccines that you're recommended, again, anyone kind of under 26 who hasn't gotten the HPV vaccine, male or female, is recommended to do it. Is highly effective. It's able to be given to patients between 26 and 45, but it's not a standard universal recommendation for that. That kind of depends upon patient's individual situation and how at risk they are being exposed to HPV and new HPV infections. And so it can be discussed with their doctor. So they're allowed to get it, but it's not a standard recommendation. But again, hopefully we're catching, as things evolve, we're catching most kind of with a goal of 80 to 90%, of teenagers at this point in the United States. How effective things are, kind of, this is one of the best graphs that I've seen in England. They've seen since again this was an older slide, but these numbers are wrong for some reason. This was in the 2000s. I don't know where they came from, but basically they've seen since this is by birth year, not the actual year that the data came from, but by birth year, since they have about an 80% uptake in England for this, they've seen that the risk of severe precancerous changes in cancer has gone, again, still a fairly small amount, 1.3%, but it's gone down to a fraction of 0.07% just by giving that group these vaccines. So again, we have similar data in the United States and similar data in Europe. And so again, it's made severe precancerous changes, which require surgery, or cancers, which requires treatment, which can be surgery and can affect fertility in younger people, has become very, very rare with the advent of this vaccine, and it's been very, very successful. In the United States, we're getting closer to 80%. 2020 data was 75%. Had got at least one dose, and 60% had completed it. In Florida, we're getting around the same range up to 2020. We're doing a little bit better than that. Now, again, it's a little bit 65%, I believe, or the latest data that I saw, but we're trying to get towards 80%. It's believed, based on data, if we can vaccinate enough of the population with the HPV vaccine, that we can eliminate cervical cancer. Again, very lofty goal, but in terms of the goals that the American Cancer Society and the World Health Organization have set by mathematical models, they said if we can vaccinate 90% of girls vaccinated by the age of 15, and also increase our screening so that 70% of women are up to date on their screening, that we should make cervical cancer, both in the United States and worldwide, a very, very rare disease. And so we're well on our way to that. Again, the World Health Organization set the targets at 90% vaccinated and 70% of people up to date in their screening. So that's what we're shooting for. In the U.S., which were the initial goal is by 2026 to try to get 80% of 13-year-olds in the United States. Like I said, we're at about 65 to 70%, and we're getting that way. But if we can do that, it hopefully will make cervical cancer a very, very rare thing for us to treat. And like I said, that the prevention is really key for something that's preventable. To have this available, it's really important that everybody get vaccinated according to the recommendations. Again, summary, the important point, it's for all boys and girls ages 11 to 12. And again, you need less doses if you do it before age 15. Again, very safe vaccine, and again, we'll try to get everybody vaccinated as teenagers, but by age 26, although you can use the vaccine later in certain circumstances. Again, that's probably all again, we're splitting this 3 ways. So in terms of things, I'll leave it to Dr. Berkowitz to highlight some other kind of what you need to know in 2024, and also leave some time for radiation oncology to talk about the developments there that are to keep everyone up to date.
Good afternoon, everyone. Happy to join this panel with my colleagues and talk about some medical oncology viewpoints. I just wanted to emphasize what Dr. Morrissey was talking about, the importance of prevention. The patients who do end up getting malignancies and may have difficulty getting initial cures with surgical procedures, those are the patients that I often end up seeing, and the outcomes are not as good. So it sounds somewhat trite to say this, but it's true. The best way to get cured of cancer is not to get it in the first place. And I think the data concerning the HPV vaccine with cervical cancer is fairly amazing. So anyway, that said, let me move on here and talk about some issues with systemic therapies, which is what I deal with primarily, chemotherapies and now immunotherapies. The traditional role for systemic therapies in gynecological malignancies, most commonly we look at ovarian cancer, where it's used in conjunction with debulking surgery. The key in treating advanced ovarian cancer is to have excellent debulking surgery. where a skilled surgeon like Dr. Marcy will go in and remove as much tumor as possible, and then we come in with chemotherapy. Patients will often ask me, well, if I'm getting chemotherapy, why do I need Dr. Marcy, or vice versa? If I had my surgery with Dr. Marcy and he did such a great job, why do I need you? Well, the combination of chemotherapy and debulking surgery is necessary for the optimum treatment for ovarian cancer. In patients with uterine and cervical cancer, chemotherapy is often used postoperatively. We see many patients with uterine cancer now who will get chemotherapy postoperatively because of certain pathological issues. And in cervical cancer, we often will use chemotherapy in combination with radiation therapy. I wanted to talk about some recent advances in gynecological oncology. That's maintenance therapy in ovarian cancer, immunotherapy, and a new drug for ovarian cancer called mirvetuximab. So what is maintenance therapy? The rationale for maintenance therapy is, despite what might seem like successful therapy, maximum surgery and systemic chemotherapy, that the relapse rates in that group of patients can be quite significant. In other words, patient goes through excellent surgery and then has the prescribed chemotherapy. We look at those patients afterwards, scans are negative, blood tests are negative. Still, there's a substantial number of those patients who are going to relapse. So it would be nice if there was a therapy that could maintain patients in remission. If such a therapy were available, it'd be beneficial that it be less toxic than the initial chemotherapy and well tolerated. So the first real maintenance therapy was a look at Taxol, which was one of the backbones of our immediate postoperative therapy. And they randomized patients to 3 months versus 12 months of Taxol after they were in remission. And the bottom line is that 12 months of Taxol after receiving prior chemotherapy is pretty tough for any patient. And the amount of benefit was relatively small. So this really failed in our attempts to get a good maintenance therapy. First of all, it was not well tolerated, and the actual benefit was not that great. So there's a group of drugs called the PARP inhibitors. The main use is in patients with BRCA mutations, for the breast cancer susceptibility gene, or in patients that we call HRD deficient in DNA repair. There was some initial data looking at it, supporting its use in patients who did not have the BRCA wild type, but that seems to no longer be the case. And there are now 3 of the PARP inhibitors available in the United States. The Rababab, Rubicab, and Limparza. I printed up the basic progression-free survivals in those studies. The first study with Zejula, the progression-free survival was 13.8 months versus 8.2 months for patients who did not receive the drug. For Rubraca, it was 20 months versus 9.2 months. The major side effects with the PARP inhibitors tends to be nausea and blood count abnormalities. Unlike traditional chemotherapy, where the longer you're on chemotherapy, the more the blood counts become affected. With the PARP inhibitors, it's interesting that the bone marrow toxicity often is front-loaded. So patients will experience anemia or low platelet counts or low white counts early on. So when I start patients on these medicines, I usually check their blood counts every 10 to 14 days until I get a sense of how they're responding. I want to talk a little bit about bevacizumab or Avastin. It's often used in chemotherapy with Taxol and carboplatin. It's not truly a chemotherapy. It's more of a growth factor inhibitor. To think about it simplistically, cancer cells need to grow and produce new blood vessels, and there are growth factors that help cancer cells produce new forms of blood vessels, and Avastin interferes with that. It can be used in maintenance therapy, usually in patients who are on Avastin during their initial chemotherapy. And we monitor blood pressure because sometimes that'll become elevated in patients with Avastin, and kidney function needs to be monitored. There was the Payola-1 study was a maintenance comparison between one of the PARP inhibitors and bevacizumab versus a placebo and bevacizumab, and there was a 22.1 month progression-free survival versus 16.5 months for those patients getting only bevacizumab. There was I wanted to switch over to now immunotherapy. Immunotherapy, you've probably all seen commercials for Keytruda and Opdivo, which are two of the more commonly used immunotherapy drugs. Immunotherapy works differently than chemotherapy. The theory is that there's a break on the immune system, and drugs like Keytruda and Opdivo remove that break and activate the immune system. And when that immune system is activated, it can increase the activity against malignant cells. So in cervical cancer, there is benefit to adding Keytruda to chemotherapy in the front line for patients with advanced and metastatic cervical cancer. We also see in patients who have a high mutational burden or a mismatch repair, which are genetic signals that we test for in the tumor tissue. There is data to support using immunotherapy for second-line therapy. For patients who are not MMR deficient, the combination of Keytruda and an oral targeted agent called lenvatinib has significant benefit in second-line therapy. And lastly, I wanted to talk about mirvetuximab, which is a brand new drug released about a year or so ago for patients with advanced ovarian cancer, what we call platinum-resistant ovarian cancer. In that group of patients who have platinum-resistant ovarian cancer, the typical response rates to any of the drugs that we use is somewhere around 15 to 20%. In the studies looking at mirvetuximab, the overall response rates were approximately 32%, with almost 50% of the patients being stable after treatment. There is some ocular toxicity, so we advise patients to follow up with their ophthalmologist. So it has been a very significant drug for us in treating advanced ovarian cancer. I'm going to pause here and give the stage over to Dr. Agarwal.
So my understanding is this is mostly a group of very interested people in our community that are not in healthcare. So I thought that I would go over some kind of basic slides about radiation oncology conceptually, and then try to leave it open for some question and answers. And if there are other questions at that time, we can go back and reference certain slides. So somehow I'm moving these forward. Okay, so cardiovascular disease is the #1 cause of mortality in the United States, but cancer is expected in the next few years to become the #1 cause of mortality in the United States. In general, we're talking about gynecological cancers, and it's, I think, an excellent panel that's been put together with an excellent GYN oncologist and medical oncologist, and they invited us from a radiation perspective. But there's some other doctors that have a critical role in cancer, especially for GYN, and that's the pathologist, who she or he will look under a microscope, usually on a biopsy specimen that someone like a GYN oncologist obtains. And then under the microscope, that's how the cancer diagnosis is made. And that's really very critical. Everything that Dr. Berkowitz and GYN oncologists and radiation oncologists do is really based on an accurate pathology diagnosis. And this is a critical doctor who you really usually never even meet, but it's important, I think, to recognize that. Same thing for the radiology. I often get confused with the radiologist. But the radiologists are the ones who interpret CAT scans, MRIs, your breast mammogram. They read those studies and they give a report. Based on that, if there's a cancer diagnosis, sometimes there's a role for radiation oncology, and that's the kind of specialist that I am, where we deliver radiation to try to cure cancers. Here, you want to just advance because it's not
Yep.
working for me. Okay, so this is a team effort. It's just showing how many doctors are involved in cancer management. Next slide, please. This is again showing the importance of a multidisciplinary approach, which is what this today's lecture is kind of reflecting, that you have input from radiation oncology, medical oncology, GYN oncologist, a surgical specialist. This is the model actually at Boca Raton Regional Hospital, Baptist Lynn Cancer Institute. And it's really an amazing model because we get specialists who are highly, highly trained in their respective areas of specialization. And we get everybody in a room and they sit together and they review the imaging and the pathology. And, everyone's a fantastic advocate for their patients, but they all approach it from a little bit of a different angle. And we sit in a room and we discuss management and possible options of patients. And it's really an ideal way to go if you can manage to be part of a multidisciplinary clinic. And that's exactly the LCI, the Lynn Cancer Institute model. And you can see that's reflected in the talk today. Next, please. Next. Next. I'm going to just fly through some slides in the interest of, I was going to do this manually, but I'm sorry. Just next, Gary. Next. So a lot of people don't understand what radiation is. I tell them it's kind of like just getting an X-ray, but it's a very sophisticated X-ray. And so there are different types of radiation. There are different ways to classify radiation. Next. So here you can see on the left side, radio waves are actually radiation. So when you walk outside your door right now, and you're just taking a walk in your neighborhood, you're getting bombarded by radio waves. They're totally safe, but that is radiation. So there's this conception culturally that we think of radiation as bad. And of course it can be. Nuclear energy exposure and things along those lines. But really, most of the radiation we're exposed to daily isn't bad radiation. It's just background radiation. So you can see radio waves, the microwave oven you've got in your kitchen, when you're walking around outside, just the sunlight, you see the little rainbow here. That's all types of radiation. As you get to the right side, which is really increased energy radiation waves, higher frequency, lower wavelength, that's what we start using in diagnostic radiology and in therapeutic medicine as radiation oncologists to try to help cancer patients. Next, please. Next. Next. Oh, go back one slide, please, Gary. So look here, this is pretty interesting. The radiation we use is called ionizing radiation, which is this purple square on the right side. All the other stuff on the left is non-ionizing radiation. It's a very, very busy slide. But if you look at the bottom, I don't know if you can put the cursor on this, Gary, but where it says tanning booths in the bottom, in the purple, go over to the right a little bit more with your cursor, and it says tanning boots. And
my cursor's not right working.
Oh, okay. I see it moving, but in any case, if you see on the bottom right-hand side corner of the slide under ionizing radiation, it says tanning boots. Look at that. That's actually ionizing radiation. So a lot of people, especially in South Florida, Miami, Fort Lauderdale, Palm Beach County, they're going to tanning booths and they're paying people to get exposed to ionizing radiation to get a tan, which I would argue is not a good idea. Just kind of FYI, showing you the spectrum here. Next, please. Next. We can come back to these if anyone has questions later about radiation mechanisms of action. Next. But basically, the radiation breaks double-stranded DNA in select cells, and that's how it causes the bad cells to get destroyed. Next, please. Next. 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 I'm trying to just get to some visual slides. Next. Next. Okay. My entire education over decades is represented in this one seesaw slide, which is the left side is efficacy and the right side is toxicity. So efficacy means how good of a job we do at curing cancer, and toxicity is just side effects. So the entire world of radiation oncology for me every day is to try to do what? Maximize efficacy and decrease toxicity. GYN oncologists, you heard a little bit earlier today, they continually improve surgical techniques to increase efficacy and decrease toxicity. There's robotic type of surgeries now to increase efficacy, sometimes in the right hands, and decrease toxicity. Dr. Berkowitz spoke with you about certain types of newer medications, PARP inhibitors, immunotherapy. A lot of this stuff wasn't around 20, 30 years ago, right? Every decade we see significant advances. What are they for? Again, to increase efficacy, decrease toxicity. That's the goal. Next. 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 So we use a lot of cool equipment. The Lynn Cancer Institute and Boca Regional have invested a tremendous amount of money and resources and infrastructure to be able to provide our patients with the latest and best cutting edge technologies, both from a diagnostic perspective to actually detect cancers, and then from a radiation oncology perspective to treat cancers. Next, please. Next. Next. Just try to wrap this up. Yeah, keep going. I'll tell you when to stop. Okay, stop there, please. So here is a woman. You see there's two pictures. So look at the picture on the right. And you see basically her breast is exposed. It's an old picture, so you can't really see her breast very clearly. But she's the first example of a photo we have of a woman, of a patient getting treated with radiation for a cancer. So she has a breast cancer, and that little black circle thing that's hooked up to an arm, that is the original machine used to deliver radiation. And you can see it's kind of pushing a little bit against her right breast area. So this is going back to, the beginning of the 1900s. And that was kind of the beginning of our radiation oncology journey. Let me show you a modern picture. Next. Here's how one of our newer units looks. So you can see there's a couch there. A woman would lay down there. Any patient would lay down on that couch, and that big machine would move around them. We use this typically for all sorts of cancers, specifically, though, for the topic today, gynecological cancers, endometrial cancer, cervical cancer. Those are two higher volume cancers that we use radiation for. And often women will come in and get a small dose of radiation every day. That machine moves around them, never touches them. It's non-invasive. And this is an adjunct to what the other doctors do, right? So Dr. Morrissey would go and do surgery, let's say, for an endometrial cancer and take out the uterus. And then he would send that patient over to us. And if she was an appropriate candidate, she would maybe receive 5 weeks of radiation on this machine. Each treatment's maybe 15, 20 minutes a day. You come in, you get a small dose, you go home, you go about your normal activities. Sometimes those women would need chemotherapy or some type of systemic type of therapy. That's Dr. Berkowitz's specialty. So we all work together, and sometimes you only need one type of therapy, and sometimes you need two, and sometimes you need three. Next. 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 Just shows you that we have lots of different cancers that we treat. We do implants sometimes in the OR. This is the left side of a woman's breast. That was one of my patients I did an implant on. Next. 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 And just keep going. And I will show you one more machine. Okay, here's our CyberKnife machine. So we have one here at the Lynn Cancer Institute. And this is also a very, very precise way to give radiation. Literally, this machine has the ability to give radiation with sub-millimeter accuracy. So it's a state-of-the-art unit. Not every radiation oncology center in the state of Florida will have one. They need the specialized equipment. It's more money, more type of training. The team needs to be expert team to be able to implement these type of technologies properly. So again, I just wanted to kind of give you a general flavor of what some of these radiation oncology type options are. And keep fast forwarding. I'll see if there's any other slides here. Go back 2 more slides, please. One more. So look here. You go back 1 more. Now fast forward 1 and let's see if it's moving. Okay, so this is pretty cool. Look at this. You see there's 4 boxes on the top and 4 boxes on the bottom. So if you look at the top 2 right boxes, you see that little thing moving up and down. That's a lung tumor. So we have the ability to gate our treatments. So what does that mean? That means tumors are sometimes moving, especially in the lungs, or sometimes for gynecological cancers, there's some movement day to day. So we have to track that movement. And so this is an example of using cutting edge diagnostic technology where you're actually seeing the tumor moving during a CAT scan. And then we use those images to very, very precisely tailor our radiation treatments. So I hope you can see on that top row, the 3rd square over, and where there's that little red box, you see that little blip moving up and down? That's a lung cancer. That's a lung tumor. So it's pretty neat to be able to track these things in real time to help tailor precision treatments. Next, please. Just keep fast forwarding slowly, please. Okay, so one more back. Yeah. So Lynn Cancer Institute is, of course, linked to Miami Cancer Institute, Baptist. And at Baptist, they have this technology called protons. This is really not needed for most cancer patients, but for select cancer patients, it's an amazing technology. To put it in perspective, when I was in training, which wasn't that long ago, there were 2 centers in North America that did protons, that had a clinical volume of protons. One was on the East Coast, one was on the West Coast. There was a small center in Indiana that did mostly research. They didn't really have a large volume of actual patients they treated. So in North America, we had 2 proton centers that had clinical volume at that time. Now, there are a number of proton centers which have gone up, and probably the 2 best known ones down here are the Baptist MCI and the University of Miami. Those are 2 well-respected proton programs. And Baptist and Boca Regional have now broken ground on a proton center here in Boca Raton. And so as I speak with you, in my parking lot outside, there are cranes that are building and laying the foundation for the proton center, which will be coming up and ready to treat patients within the next few years. But that's really an amazing accomplishment, I think, for our Boca community and Boca Regional area. Again, protons are not appropriate for every single patient. but this gives you an idea of, this is the last slide I'm going to show you, then I think we'll have 15 minutes for questions. This is a patient of mine from up north, actually. This was a child. And if you look at the top, the top box on the top left, where it says protons, on the right side of that box, you can see it looks kind of like the head of a person. So that's literally the head of the child. And he's facing downward. So he's like kind of laying on the bed, laying on a table, looking down, like your face is into the pillow. And that purple box that you see is the spinal cord. And so with the protons, we deliver the protons and we have the ability to limit the dose just to cover the spinal cord there. And that's really pretty critical in certain types of patients and for pediatric patients where they're still growing. And when they're growing, they're exposed to radiation. And when they're exposed to radiation, when they're growing, that can have long-term side effects for them, provided obviously that they're able to overcome the cancer and move forward. So this is a classic example of where protons are extremely useful. This is a medulloblastoma in a child, and this is like a classic example of where it would be used. But again, this is a team approach at LCI and MCI at Miami Cancer Institute, Lynn Cancer Institute, where we sit down and we discuss these situations case by case in our multidisciplinary tumor boards, and we figure out literally what's the best treatment for each patient. We try to do our best to do that in a teamwork effort. And part of that is, of course, having great doctors and caring doctors and nurses and support staff. And part of it is just having access to technology. So I wanted to kind of give you just a quick overview of that. That's it from my end. Thank you.
Thank you, doctors. Let's see, it looks like we have a couple questions for one. Dr. Morrissey, can you see the question? It looks like it would be for you.
Yeah, the question about breast cancer and HPV.
Yes.
Yeah, no, there doesn't appear to be a relation between the two there in terms of and there's been no correlation between HPV vaccination and any infertility or any breast cancer diagnoses. There's no data on any of that, and it wouldn't really seem to be related.
Okay, thank you. Do we have any other questions that people can jot down into the Q&A? I think everything, thank you, doctors. You covered every possible topic. It was very informative, and this is what we appreciate, being educated. And this is for the community, but we also have quite a few of our Boca Regional staff that attend these lectures, and it's good for all of us to be educated. So we appreciate you very much. And we'd like everyone on this presentation to know that on Wednesday, January 24th, we're going to have our nutrition lecture that will be titled Fueling Your Exercise. And our clinical dietitian, Katie Wolke, will be the speaker on that. And we want everyone to remember our Run for the Ribbons on February 4th. This is our 13th annual, so we welcome you all to come and attend. And on the same day, we celebrate World Cancer Day, and we celebrate our patients, their families, and friends. They come for a brunch and also to paint a tile that will adorn our walls, as I'm sure everyone has experienced. So if anyone on this broadcast would like to register, please just contact myself or Lee. And Lee will be sending out an evaluation form, and we appreciate you completing it. It helps us to add you to the database. Also, if you have any comments, that we appreciate those. And Lee will be able to send a link if you would like to share this presentation to anyone that was unable to make it today, or if you'd like to review it yourself. This has been recorded. So thank you, everyone. Happy Friday and have a wonderful weekend. And thank you, doctors. We really appreciate all the time and effort and expertise that you put into these presentations. It's greatly appreciated.
Thank you.
Goodbye, everyone.